Good day, my name is Dean Johnson and today we'll be discussing shoulder dystocia. Entering the room to my right is Chris, he'll be my second officer, and Jason will be my third officer assisting with the birthing through the mannequin. On entering the scene we assess the mother and gather a quick rapport and find out how far in labour she is. Assessing that she is in imminent delivery, we start applying PPE gear. That includes gloves, gowns, mask and glasses. Whilst doing this, I will be setting up a resus bay whilst asking mother her history of pregnancies and births and if she's had any complications with births. Next, you can see we've put a towel on the resuscitation area. This is to ensure that we help maintain a patent airway if we do need to resuscitate the baby. So you can see that allows us to have an ear to sternal alignment as the anatomical position of a newborn's head doesn't allow this, and this assists with that. After that we prepare the bag valve mask and oxygen. So we need to ensure that we have adequate oxygen. Grab the neonatal bag valve mask, make sure that's working, plugged into the O2, not necessarily on. Next we'll grab a size 16 gauge suction catheter, make sure that is working and apply that underneath the right hand side of the pillow. Next we will make sure we have OP sizes that are appropriate and ET tubes at hand's length. We'll turn the defib monitor on to defibrillation mode and grab the neonatal pads and apply the correct jewelage. And then last but not least we have a warming bag, and this is to ensure if the child needs resuscitation. And warming, we've got a bag handy to keep a child warm, including warming blankets. Moving back to the mother, we've established that she is in third tone labour. We'll continually apply PPE and make sure that the birthing area is hygienic by applying blueies and making sure that we have a clean working space. Once a child's head's been birthed and we have established that we have turtle sign, we need to communicate with the mother and the crewmate that we have a suspected shoulder dystocia, as well as calling for backup as more hands with the maneuvers is preferable. With the first maneuver we'll be doing is called the McRoberts technique. This is when we have the mother's legs pushed back as far as possible whilst applying downwards pressure without pulling on the infant's neck to try and dislodge the infant's anterior shoulder from the pubic bone. Emphasizing on pushing the mother's legs back as far as possible. This is very uncomfortable and unpleasant for the mother. And continuously trying to dislodge that shoulder with a downwards motion without pulling the child's neck. When that is unsuccessful, we move on to suprapubic pressure. This is when you get the mother to hold her legs back as far as possible, whilst the second officer applies pressure in a downwards horizontal motion, trying to dislodge the anterior shoulder of the infant, whilst the main operator continues to put downward pressure on the infant's shoulders without pulling the head. Once that's unsuccessful, the next movement would be suprapubic pressure with a rocking motion. This is when the second officer continues suprapubic pressure with a rocking backward and forward motion to try and dislodge the shoulder from the pubic bone, with continuous downwards pressure from the main operator, whilst the mother holds her legs back. When this is unsuccessful, we move on to the Gaskins maneuver. This is when the mother's on her back. We get her to try and move on all fours with assistance or non-assistance. This is up to the mother. Once the mother gets herself up, please being aware that her legs may be quite sore from the previous maneuver. Get the mother to do a running start motion. This is going backwards and forwards. As you can see, the one leg's up, and this helps with dilation of the pelvis. With a backwards and forwards rocking motion, this helps change the angle of the pelvis. If this is unsuccessful, we swap legs and try this for another couple of seconds in an attempt to try and change the angle and increase the diameter of the mother's pelvis. This might be uncomfortable for the mother, so be aware and continuously be supportive. When using Gaskin's maneuver, it's no specific order whether you do the running start first or the all fours position, and try and help the mother get down her face as low as possible, as this assists in enlarging the pelvic area. And here we'll be demonstrating the internal maneuvers of what it looks like from this view. This is axial traction. It's not pulling on the head, but really trying to pull on the shoulders with the downwards tension. In this clip we'll be demonstrating how to perform the suprapubic pressure. As you can see, there's a pubic bone. We apply the suprapubic pressure above the pubic bone in a downwards lateral direction, not pushing down on the pubic bone. The next internal maneuver to use is the Rubens maneuver. This is when the clinician inserts their right hand posteriorly inside the vagina alongside the dorsal aspect of the fetal shoulder and rotating the shoulder inwards, abducting it to about 30 degrees until the shoulder lies oblique diameter of the pelvis. If that is unsuccessful, we move on to the wood screw technique / maneuver, which is an addition to Rubens maneuver. The fecal trunk is rotated to at least 180 degrees using pressure on the dorsal aspect of the posterior shoulder, helping it to abduct the shoulders, and the rotation is done in a screwing motion. Once we have cleared the shoulders off the pelvic bone, we deliver the posterior shoulder and arm and begin postnatal cares. Bringing the newborn towards mother for skin-to-skin contact. Apply thorough stimulation to bub, avoiding suction, as this has negative effects due to aspiration. Lots of drying mouth and face. Applying new blanket to the newborn and try and keep it warm, and encourage mother to breastfeed, and at the same time performing an APGAR score on the newborn. If there are no further complications with the newborn, we will move on towards clamping the umbilical cord once it has stopped pulsating. We do that at every 5 centimeter increments, as demonstrated in the video, or using a fist as a guideline, starting towards the newborn. Once we have clamped, we cut between second and third clamp, removing the umbilical cord. Once we notice lengthening of the umbilical cord, we can safely assume that the placenta is now delivered, and normally a bloody show will happen. Once the placenta presents itself, we grab the placenta, and in a twisting downward motion, we deliver the placenta. Once we have delivered the placenta, we inspect the placenta to ensure that there's no placental matter left over and that all membranes are attached. If all is in order, we put the placenta in a bag and continue our postnatal cares and transport mother to hospital. Thank you for watching.